Welcome. I'm sorry about that. So welcome to this session. This is going to be an evening session. It's a new month. I'll try and keep it simple as I'm trying to get to learn everything matters TikTok. Let me start charging. The poet, welcome. I'm so sorry. Hi. Let me try and get a charger. Can do this. Okay, it's nice to have you join. Pruden, thank you for joining in. Chapkirui. Okay, let's keep on trying to go. I think, let me introduce myself. My name is Dr. Liz. I'm a general surgeon, but I want to dwell on matters health, especially surgical, the surgery aspect and surgical education. I'm passionate about surgical education and empowering people to take care of the health. And since October was a big month on breast cancer awareness, I thought maybe we could just go along or start with that. We do know that the rate of cancer is increasing. I did a TikTok live yesterday and we talked about the cancer rates that are increasing worldwide. Breast cancer is the most common type of cancer in the whole world. It's up to 22 million of new cases that are diagnosed in the whole world. And out of those, close to 700,000 people die every single year. In Kenya, we have 7,000 to 8,000 new cases as of the last year. And of those, 50%, 40 to 50% of those succumb. So in the spirit of just increasing awareness, increasing advocacy on matters health, because I believe whatever God has given you and you're able to use, we should be able to use it to help people. And some might have false assumptions. It's good to demystify some of those assumptions, as it is better to get it from the horse's mouth. So if you have any questions, any queries, you wish to comment or just ask, feel free. You can also reach out to me directly on my DM, but it's nice to be here. This is the second time I'm trying this. I did this yesterday as we did a brief discussion on what breast cancer is. We talked about how to do a breast exam, a self-breast exam, and we can handle that a bit later. But today I wanted to handle the false assumptions and the false myths that surround breast cancer. So allow me to try and see if I can twist this and charge my phone as we continue to do this. So I hope you guys have had a good day. I hope some people got to rest a bit since we had a gazetted public holiday that we were not all aware of. Let me adjust a bit. I don't know if that's okay. We will work with it for now. Yeah, so thank you for joining in, Samir, Faraja, Mamchiri. Today we're talking about breast cancer. We're talking about the false assumptions And then I'll just end by talking about how to do a self-breast exam. We will have a practical demonstration with clothes. I don't have a dummy, and we will do it practically. If you have any questions, reach out, call a friend, share this to invite more friends so that we get to learn with each other, so that we get to talk about the things that we normally don't get the ability to talk. Hi Sydney, welcome. Sultan. We don't get to talk about health. It's so funny that we can talk about many things, but when it comes to health, especially like the intimate parts of health, what breast cancer is, how to do a breast exam, it's so difficult. And we're going into a month where we'll be handling prostate. November is called the prostate men's month, prostate November. So I'll start talking about the prostate and men's health. And if you have anything to ask, please let me know way before. If there's any men's health, I want to talk about the prostate, what you should know about the prostate, what you should know about enlarged prostate and how different it is from cancer. So there's benign prostate enlargement and prostate enlargement that is not cancerous, that comes with age. And then there's prostate enlargement because of cancer, and how those are totally different things. And then there are sexually transmitted infections and how that affects the man, how you can get a blockage of the passage, what we call urethral stricture. So let me purpose, and you can hold me accountable, that every single day at least we can try and talk in the evening on issues to do with men and women's health, mainly from a surgical perspective. For the women, let's talk about breast disease. For men, we can talk about the prostate, because that's very important. Jairo, welcome. Faraja, welcome. Are there any comments? You can let me know how to check on that. Yeah. So let's see. So let me go through some false assumptions that I know that we have. We all know that I've talked about it. Breast cancer is increasing. Kenya is still within Africa, and in an African setup, the rate of people dying is still high. If you get to have a diagnosis of breast cancer when it's early, then it increases your chances of survival. When you diagnose it early, when you go for treatment early enough, and when you go through the whole course of treatment. And the whole course of treatment can be either you're examined by the doctor. If they feel there's a growth, they do an investigation. The two most common investigations they will ask for is an ultrasound or a mammogram. A mammogram is known as a screening tool. It's mainly used for women who are above 40 years of age, because their breast tissue has become less dense. In a younger female, those ones who are less than 40, the breast is composed of fat cells. It's composed of fat cells. It's composed of the milk-producing cells, but then it's also composed of things that we call connective tissue. And when you're younger, your tissue in the breast is denser. So the mammogram might falsely pick those as, growths, but that is not what it is. So for people who are younger, we use the ultrasound. The ultrasound is able to clearly tell whether there's an abnormal tissue that is different from the dense breast. And sometimes people can have a diagnosis of breast cancer they might have a normal breast exam, and then when they look at the armpit, they find that there's a growth. So we call those hidden types of breast cancer. They are very rare, but they are also now becoming more common. I think I'll handle how to do a self-breast exam before we go to the common myths and misconceptions. Please invite friends. Lucia, thank you for joining. Eunice Kageha, thank you for joining. So I don't know if you're able to, yeah, you can see that. To see that, I'm supposed to be looking. Where am I supposed to be looking? Yeah. So how do you do a breast exam? Yesterday we talked about this. So we're lucky that God gave us a pair of breasts. In any other animal, you always see that they have a line. We call it a mammary line, where the breast tissues are lined. So in a cat or a dog, you see that they have the breast buds on a particular line, and that line would normally run from under the armpit and come to the chest, and in the other animals it will go all the way down. Not to get into the details, but the beauty of what God did is he gave us two, which is a pair of breasts, and they're located on the chest next to each other. So if you're to compare anything, you don't have to go and call your friend to compare their breast and yours. You're comparing your own. So one, you need yourself. You need a good mirror that you stand in front of, and then you need to relax as you do this exam. Look for a quiet place. Let's start with when you do the breast exam. Breast exams are done at least a week to 10 days after your menstrual period. We all have a menstrual cycle, and the days when we go on our menses, when, you know, like the uterine tissue or the lining of the uterus tends to, you know, just get shed off if there is no pregnancy that occurs. And then you start, the ovulation cycle starts all over again. So at week 7 to 10 is found to be the best time to do a breast exam. The hormones, the two main hormones, estrogen and progesterone, would not affect would not really tamper with the density of the breast. So look for a time. Now you might be on contraceptives and you might not have a normal flow, or you might have an implant and you actually do not even see your periods. For such women, we advise pick a regular time and be consistent monthly. The self-breast exams should be done on a monthly basis. You should do it on a monthly basis. Be consistent. The more you do it, the more you become certain about how well you know your breast tissue, how well you're able to do the breast exam. Look for a quiet place. Preferably do it after you have showered. I'm trying to see Orinda, Seth, Karibu, Messi, Karibu. Look for a quiet place, which will probably be in your room. You have showered. It's quiet, maybe in the morning or in the evening, and you have some time to yourself. Stand in front of the mirror if you're able to, and you start by just looking. We call it inspection. And when you're inspecting, you're looking at the breast. So you've either dressed down or you've opened the towel and now you're looking. And when you're looking, you're just examining both breasts. How are they looking? What is their shape? It should be cylindrical. If you're younger, it's more, you know, formed and circular and, you know, just like a young lady's breast. As you grow older, as you have breastfed, they tend to be a bit lax, as, you know, for the menopausal, you know, as you're going through the different, you know, developmental stages or years, the density of the breast becomes less, so it becomes a bit lax, so it tends to be a bit more pendulous and might hang a bit, but you're able to tell. So whether it's big breast or whether you have a small volume breast, you're still able to tell the symmetry of your breast. Are they the same? Do they look similar? Now, you might notice that for anyone, you might see that you know perfectly that one breast might be just slightly, it's almost like twins. You can tell the difference between the twins. So with you, even with your breast, you might tell that one is slightly smaller, but you're looking for abnormal discrepancy in the size of the breasts, in the shape. So does one look not cylindrical? Does it look like this is being pulled or tethered to the side, like something is putting traction on it? So that's just by looking. You're looking at the shape, you're looking at the whether it's curvy, you know, curving. You're looking at any skin changes around on the breast tissue itself, or on the nipple and the areola region. We call it the nipple areola complex, that central part where the baby normally suckles from. So that area, does it also look circular? Are there any skin changes you note? Are there any wounds? Does it also look like it's abnormal and it's pushed to one side? A normal nipple should be everted, facing outwards. Does it look like it is inverting? Is the nipple looking like it's inverting inwards? If it is that new? Some people maybe were born and it was not inverted, or when they get pregnant and they start breastfeeding, that initial stage, the nipple looks inverted. But is this a new change that you're noticing in your breast, that it's inverted right now? So we've gone through shape, you've gone through the nipple areola region, whether there are any skin changes, whether the nipple is inverted. And then on the skin itself, are you noticing that the skin looks a bit dimpled? Does it look like, how you peel an orange and how that orange peel looks like it has dimples? We call it poudre orange. Is that looking abnormal to you? It's not been there. And then, yeah, that's just on examination of both of them. And is there any wound? Have you been scratching? Is there any region around the nipple areola that looks like it's flaking and that has not been there from before? So as you keep on doing this every single month, it becomes easier for you. So that is just inspection. And then the next thing is to put your hands akimbo. And when you put your hands akimbo, Fema, welcome. When you put your hands akimbo, I want you to make this motion, stretch your hands out and have them move. As you're doing this, as you're stretching them out, as you're moving, you're looking at the mirror. Like now I'm looking at myself. You're looking at the motion of your breasts. Are they moving equally together, symmetrically? Remember, you have exposed yourself in your own privacy. You're able to do this relaxed. So you're looking at the mirror. You're looking at both breasts. Are they moving symmetrically on both sides, or does one side look like it's tethered? Is one side moving slower than the other? Is one side fixed to the chest? Yeah. So you look both of them, and then again lift your hand up and start moving it in a slow motion down to hands akimbo. So you're doing this as you're looking, and the thing you're looking for is you're looking for the mobility of your breasts. Is one seemingly fixed or rigid and is not moving as well as the other freely? Then turn to your side. As you're turning to your side, bend forward. When you're bending forward, you're looking at whether the breast is able to move freely. Is it pendulous? Is it moving freely? Or does it seem that it is still stuck or tethered to the chest wall? Those are telltale signs. And then you come back. So you're done with inspection. Now you need to lie down. You need a bed in the room, and the left hand examines the right breast and the right hand examines the left breast. And when you're examining the breast, you're mainly using these portions of your fingers, this portion. When I'm left-handed, so I'll start on the left side. So as you do your examination on the left breast, place your right hand behind your arm, lie down. Use the palmar aspect of the second to the fourth fingers. And you can do the breast exam in 3 different ways. One, you can do the up and down motion. So when we look at the anatomy of the breast, imagine this is one breast, and it starts from the second rib below the collarbone. It goes out laterally to under the armpit. It goes to this lateral aspect of your anterior of the chest wall at the front, and then there's what we call the inframammary line, that fold that where the breast kind of folds. So that's the lower portion or the boundary, and then there's this outer aspect of the chest bone, this middle chest bone. So that hole is one breast and one on the other side. And most of your breast tissues tend to be on the outer upper side. We divide the breast into quadrants. So there's the outer upper, there's the outer inner, there's the lower inner, and there's the lower outer. And when you're examining the breast, you can either do a circular motion, or you can do an up and down motion. And even when you're doing those motions, your movement is just small, subtle movements next to each other, gradually. So if it's up and down, you're starting right at the underarm of your armpit and you're going in a circular motion, pole, slowly, and you're pressing gently, you're examining the breast tissue, not the ribs. Once you get to the lower portion, you just move slightly to the inner aspect and do the same. And you're moving gradually, slowly, and you're coming up all the way to that region below your collarbone. We call that the clavicle, and moving out inwards until you're able to do up and down all the way to this middle aspect. Okay. That is one side or one method. Sylvia, welcome. David, welcome. Or you can use a circular motion. And the circular motion, you're doing more or less the same thing from the region below your armpit. You're going in a circular motion, either on an outward in. You're starting from the outer aspect, gently as you go in. So if I was to describe that or to draw that for you, because a picture speaks 1,000 words, let's assume this is the breast, and that's a nipple, and that's a breast, and that's a nipple. I don't know if you're able to see this. Yeah. So this is the region under the armpit, right? That is the arm. This is the arm. So what we do, you're doing up and down, small gentle movements all the way. And then once you get to the lower portion, you come up, come again, middle portion, go, all the way to the lower portion and move in until you get to this portion that is next to that collarbone, which is sitting right there. That is the up and down method. The circular motion, basically you can start either, really trying to do this, from outward, going circularly as you come all the way to the inner aspect, or you start from the nipple. This is the nipple areola. This is where the dark skin tends to be, normal dark skin, whether you're Caucasian or you're dark skinned like me. So you start slowly, gentle motions from the inner region, palpate, make motions as you come out. And the whole idea is you're feeling for any abnormal bumps, any abnormal growths, any lumps. We talk of lumps that is not normal, that does not feel like normal tissues. If you do this on any other time, especially for young ladies, you'll realize that your breast tends to be a bit bumpy. But an abnormal lesion can either feel rubbery, it can feel like a pea, or it can feel like a mouse. You know, that ball, if you're as old as me, in a computer, what do we call it? The mouse itself. So it can feel rubbery, or more, it can feel like it's moving a lot. So just do that. That is more your feeling. And when you finish, the examination is not complete until you're able to do that final examination. And that final examination, you're supposed to do the same thing, but you're feeling on the inner part of your armpit. That is where we have lymph nodes. And lymph nodes are basically tissues where your immune system takes up abnormal cells into the lymphatics. So if there's anything abnormal that is growing, that is cancerous, they tend to drain into the lymph nodes, which will be found in the axilla. Again, do your breast exam, finish by examining under the armpit, and then it is not complete until you do this one last thing. You have to press on the nipple. Yeah, you have to try and express or press on the nipple. And pressing on the nipple just tells us whether there's any abnormal discharge. What is abnormal discharge? On any normal time, as other than when you're breastfeeding, you shouldn't have any abnormal fluid coming from your breast tissue. So if it is fluid, look at the color of the fluid when you're expressing right now, when you're doing the breast exam. Is it clear? Is it brown? Is it milky? If it's milky and you're breastfeeding, if it's milky, it might be just some hormonal changes. But the telltale, or the thing you do not want to see, is any bloody nipple discharge. For most ladies who are postmenopausal, the ducts where the breast milk used to come tend to be lax, so they can be filled with fluid. That fluid tends to be either greenish or darkish brown, but still it's not normal. You should see a doctor if you see that. So this is done on both breasts. So same thing, if it's the right breast, the right hand goes behind the head. The left hand, you use these 3 fingers and you examine. Either whether you use the up and down method, gradually, up and down, up and down, up and down, or whether you use the circular motion, and know that it is small, relaxed, gradual motion. You're checking, you're examining, you're feeling, you're taking your time to completely cover the entire breast, and then finish by examining under the armpit. And sometimes if you're small-bodied, you might feel ribs and you think that's abnormal. That is normal. And then you finish by also trying to express and seeing whether there's any abnormal discharge from the nipples. You can go to YouTube, you can go to Google and just write how to do a self-breast exam, and you might get more demonstrations, but I hope this has helped someone. So as we continue, I also would like us to go through what are some of the false assumptions, because we need to demystify these assumptions. Let me just reposition this as others join. Grace Wandere, welcome. Kiprotich Langat, nice to see you. Kiprotich. Hello. Kingi Mochache, it's good to see you. Let's do this. Let's have these discussions. So what are some of the false assumptions that we can talk about today and highlight for those people who've never had the chance? False assumptions about breast cancer. Number 1, excuse me. Common false assumptions. Winnie Rono, come join in. It's nice to have you. So some common false assumptions and myths about breast cancer. False assumption number 1, that only women get breast cancer. This is common. Guess what? While breast cancer is common in women, 99% of breast cancer are found in women. 1% of all breast cancers will be found in men. So let's say the current rate of breast cancer in the world is 22 to 23 million people are diagnosed with breast cancer every single year, according to WHO, as of the year 2022. So if that is the rate, 2.3 million cases are diagnosed every single year. If 2.3 million cases of breast cancer are diagnosed every single year, 1% of that is 230,000. But to be more exact, 1 in 833 men will be diagnosed with this disease. Yeah, 1 in 833 men. That's what it means. 1 in 800. So let's say 1 in close to 850 men. 1% of breast cancer. 1% of breast cancers are found in male. Now, the male cancers will tend to happen at an older age, as the testosterone level is getting lower. As we get older, testosterone is easily converted into estrogen. And you can see that. So for older men, if you notice, sometimes the older people, our grandfathers or our parents, they tend to now start getting enlargement of the breast. They can get, we say, gynecomastia, and that is in old age, and that's because there's more conversion of that testosterone to estrogen, and that puts them at risk of getting breast cancer as well. I think the diagnosis would be easier, but because of the fear of the unknown, the fear of being told what they have, the shame and the lack of know-how, they tend to stay back, and they get diagnosed really late. Not unless there's a family history. If there's a family history, then some will occur at an earlier age. Myth number 2. Wearing a bra increases your risk of breast cancer. Have you heard of that one? If anyone has heard of that, please put a mark or something. Wearing of bras puts you at risk. There is no scientific correlation between wearing bras and an increase in the risk of breast cancer. I think wearing a properly fitting bra will help you so that you don't get back pains and you don't get any posture problems. So look for good bras. Most not hospitals, most places where they sell good bras, not the mtumbas, would be able to fit you out to get to know whether you are a cup A or a cup B or a cup C or a cup D, and look for good bras. Get good cotton bras just for a normal day to day. You can get the nice silky ones when you want to feel good. Whether they have straps or not straps, bras do not increase your chances. There's no scientific correlation. Please remove that from the false assumptions. Are we together? Bina, welcome. Number 3, breast cancer is always hereditary, which means like it's within the family. 5% of the breast cancer would tend to be familial or hereditary. So most of the cancers are not within a family history. Those cancers which are familial, inherited, are lower in terms of the percentage. So 5% of the breast cancers tend to be hereditary. And of those that are hereditary, they are normally linked to a mutation. 2 main mutations, we call them breast cancer 1 and breast cancer 2 mutation. These mutations can be tested, although they are very expensive. At the moment, most of these mutation testing kits are normally not available in country, but we take samples and they are sent out mainly to South Africa. They get tested and we get the results back. There are other gene studies that you can also do, but the way to know is, 1, is there family history? If you ask within your home, was there a grandmother or someone who died female who it was not known, and within the same genetic line, whether it's your grandmother, is there a family history? Is a mother in the same line or an aunt of yours diagnosed? You have a sister. If you have that history in the family, kindly see a doctor, so that if there needs to be those tests done, we normally have a testing, we call it a screening, some questions that we screen. In developed setups, they have a Gale model test. Mainly looks at the age at which the family history, the people that got affected, the numbers, the age at which they were affected. If it is your grandmother, then your mother. If it gets younger, then you're at a higher risk. The mutation studies are done, and based on the mutation studies and the percentage of the score that you get, then we're able to work with you on the treatment. And for some people, I know, we all know Angelina Jolie, and we know that she got prophylactic. She actually removed her breasts because there was this genetic link within her family. And in our country as well, we've gotten some other people who've actually taken the initiative to get we call it prophylactic mastectomy, to remove the breast, as well as to remove the ovaries to reduce their chances of getting breast cancer. And it doesn't make you less of a woman. Myth number 4, having a lump means you have breast cancer. I think not all lumps are cancerous. And in young breasts, the dense breasts, you can have some lumps, which we call adenomas. Those are not cancerous. They occur as the breast is developing. They're normally less than 2 centimeters. They're small, they move, they're pretty mobile. If they are small and you get to see a doctor and they do an ultrasound and it shows it's benign, it's not cancerous, based on how it appears on the ultrasound, how it feels on examination, and if a biopsy is done and it confirms it's not a cancerous lesion, you can either follow it up. If it is getting bigger, some get big, they can be removed because there's that anxiety even with us. But even with removal, for as long as you're within that reproductive age, there's a higher risk of it coming back, or just the breast forming other abnormal tissue. So not all growths or lesions in the breast are cancerous. They can be just normal growths, benign growths, what we call fibroadenoma. You can also have collections of fluid, which we call cystic lesions. And then in women who are breastfeeding, sometimes you can have the milk ducts get clogged up and they form these collections of milk pockets called galactoseals. But it is always important to get a clinical breast exam by a doctor, to get screened and have an ultrasound done for evaluation, and have the doctor be the one to tell you that they have done everything, they have examined you, and it is not cancerous. Myth number 5, only older women get breast cancer. Guys, we are seeing a trend. We are seeing breast cancer incidences coming to 10 years younger. So the most a few years ago, the rate or the incidence of breast cancer tended to occur in women 55 and above, but we're seeing a decline in that. We're getting younger females getting breast cancer into the age of 20s and 30s. There might be some familial predisposition to that, but do not say this is an old woman disease. If you see anything abnormal, go and get checked kindly. What are some of the risk factors we talk about? We've talked about family history, which will only account for those who have the family history, 5% of the breast cancers. But we have two main active hormones in our bodies as women and men, but mainly in the women. We have the estrogen and the progesterone. When we are born, because we've come from the mother, the level of estrogen and progesterone tends to be high, but immediately we're born, because of a regulatory system from the brain, it tends to shut down, the levels go down. When we get to the stage where now we're in our reproductive ages, it now starts rising, and then you have the ovulatory cycle. So depending on which phase of the ovulatory cycle, your estrogen levels tend to be high, and then there's a break and the progesterone levels come up as the estrogen goes low. So if you're in a state where you have a constant production of estrogen cells for estrogen hormone for a long time, your cells are exposed to the hormone that is responsible for cell duct development. So what we tend to do is we associate a prolonged estrogen state to increasing the risk of you getting breast cancer. What do I mean by that? When we get pregnant, your progesterone tends to rise and it breaks that estrogen surge. When you are using contraceptives, it breaks that cycle, it brings in progesterone. When you're breastfeeding, the same thing. So any woman who's exposed to a prolonged state of estrogen, so if you had your menses early and now your menopause is late, that's a prolonged exposure. Whether if you did not have the breaks, so you have no children, you never breastfed, that is a prolonged estrogen state. If you are male or female, and alcohol tends to, alcohol intake puts you at risk, but obesity as well. Obesity changes the fat cells into estrogen, so it also increases your risk of breast cancer. So those are some of the things. If you previously had a past history of breast cancer, you can have a risk of recurrence of breast cancer. If you are younger and you got radiation therapy to the chest, it still puts you at risk of getting breast cancer. So some of those are just risk factors, but older women, the myth was only older women get breast cancer. Even younger age groups get breast cancer. Mammograms are dangerous and cause cancer. The mammogram that tends to be used to diagnose breast cancer uses very low radiation, and nowadays it tends to even be lower and more focused to the breast tissue alone. So mammograms do not put you at risk. The radiation used is very low. It's different from radiation therapy, which is used to kill cancerous cells. So mammogram is a screening tool. It does not increase your risk of cancer. It is what we use to actually diagnose breast cancer. Myth number 7. So remember, regular screening. And regular screening would include doing a self-breast exam, getting a clinical breast exam, and you getting either an ultrasound if you're less than 40 or a mammogram if you're above 40. Regular screening will reduce your chances. It will increase your chances of getting early diagnosis, and it saves lives by catching the cancer at an earlier stage, which is more treatable. Myth number 7, diet and lifestyle choices have no impact on breast cancer. Eating a balanced diet, regular exercise, avoiding excessive alcohol intake have been associated with reducing the risk of breast cancer. It can significantly reduce your risk. So maintain a healthy diet, exercise regularly, watch your weight, avoid, getting obesity. The alcohol intake also reduce that. It goes a long way in reducing your risk of getting breast cancer. Myth number 8, breast cancer treatment always involves a mastectomy. What is a mastectomy? Mastectomy is removal of the breast. While in one way or another, depending on the stage of diagnosis and the size of the lesion, and this you will have a discussion with the doctor, breast cancer treatment can be divided into the medical part of it, where you will have a discussion on chemotherapy, and depending on the stage that you are in, the chemotherapy can be given before surgery most of the times, and the aim there is to reduce the cancer burden within your body before surgery is done. The type of surgery is dependent on, 1, the size of the growth, the staging, and whether there is any presence of lymph nodes below the armpit. And by and large, these two have now been treated differently, such that we treat the axilla separate from the breast even when we have breast cancer. So there will be tests that will be done to see. Even the biopsy can be taken of the tissue below the armpit to ensure that, 1, it is there are some cancerous cells, and then there'll be a surgery to remove the lesion on the breast. If you do decide with your doctor to maintain your breast, then you need to know that the other thing that will need to be done is you need to go for radiation therapy. But you cannot have a breast conserving surgery without radiation therapy. If you do decide to have the whole breast taken out, then even with that, depending on the stage, you might still need added radiation therapy, and there'll be treatment to the armpit. And we can talk about post-mastectomy care of yourself. Even with the mastectomy nowadays, is a push, and I would encourage any patient who has to go through this to talk to your doctor or your surgeon about reconstruction. Yes, if they're removing the whole breast, can they reconstruct? Can they do can they place an implant, or can they reconstruct in a way that now you can actually still have the breast area have an implant or have tissue that is rotated so that it can still have the image or the look of a breast? So chemotherapy, we've talked about this chemotherapy that is mainly drugs that is given intravenously to you to kill the cells within the blood system. And then we have surgery, and there's surgery that is localized for the breast itself, and there's surgery that is dedicated to the axilla. Before all that, you will need a biopsy for diagnosis. And even after that, then there's also post-operatively, depending on the results that come after the mastectomy has been done, there might be a need to continue with the chemotherapy, what we call adjuvant treatment, and an add-on radiation. And the radiation majorly works to kill locally the cells if they are present or if there's any remnant on the chest wall and the axilla as well. And even after that, within the breast cancer treatment, there's the hormone receptors which reduce the chances of the tumor coming back. So there's hormone therapy that you will need depending on whether you are premenopausal or postmenopausal. So not to use too much jargon, but treatment for breast cancer is a combined, it's multimodality. There are teams that come to discuss the best treatment for you. Myth number 9, I asked this from someone. If you're diagnosed, your life is over. Early diagnosis increases your survival rate. If you get a diagnosis, if you're concerned, yes, there is fear of the unknown, of being told that you have the lesion that you have on your breast might be cancerous. But imagine if you get tested early and you get treatment early, it increases the chances of you having a more than 90% survival rate. And that will be best determined by the earlier the staging, the lower the staging, the higher the survival rate. The more complete you get in terms of treatment, the higher your survival rate. The more times you're able to follow up with a dedicated oncologist also, it increases your survival rate. So breast cancer is not a death sentence. Breast cancer is treatable. Survival rates in the developed countries is more than 95%. Let us try and purpose to do that in our country. Myth number 10. You can detect breast cancer on your own without screening. The main purpose of screening, how we see screening, is we use a simpler form, a cheaper form of a study, an investigative study, to allow people, as many people as you can, to have the ability to get tested early so that they can be treated early. So screening tools are imaging or a procedure. If we talk of something different like colon cancer, the screening tool will tend to be an endoscopy, where a camera, a tube, an endoscope is put through the tract or the lower tract to see if there's any cancerous cells, and that is done for patients who have family history. But for breast cancer, the screening tool is an ultrasound for people who are less than 40 years old, because the tissue is that dense, or more than 40-year-old, you use a mammogram. And what the mammogram just tells us is there anything abnormal within that breast tissue? Mostly on screening, it will tend to be normal. But if it's abnormal, then it just tells you there's abnormal tissue, kindly go get checked. So a self-breast exam can miss a small lesion, but a self-breast exam will help you identify something abnormal way early than just waiting until it has grown. A clinical breast exam also, although a clinical breast exam will only come if you present yourself to the doctor, can also miss out, because some breasts might be larger volume and you have to cover a lot. But with an ultrasound, you're able to look at the breast in totality with the ultrasound. And with a mammogram, when they take the image, you're able to look at the whole breast tissue and be able to detect if there's any abnormal things. Are there speculations or scarring that is not normal? And an MRI, we rarely use it, but if someone has had breast cancer before or has had surgery on that breast, then we now tend to use a higher test, which is the MRI. So screening is very important and it goes a long way. And sometimes you can get screening and it will be negative. So if you notice anything abnormal, just go and get to see a doctor. Then the doctor will best guide you on the imaging modality to use, or to help diagnose. So you do need the doctor, you do need the screening tools to help come up with a diagnosis. So I think I've covered 10 main myths. I don't know if there are any other myths that you have or you would want to discuss, but it's important to have these discussions, have these candid discussions. It's important to talk about what false assumptions. Yeah, I've heard of, if you walk barefoot, because of that energy will just remove all the cancerous cells. But you can walk barefoot and you still have a breast lump. You need to get it tested. Can you get breast cancer while you're pregnant? Yes, you can. So even if you have a breast lump and you're pregnant, don't wait until after delivery. If you see a doctor and they tell you to wait until after you've delivered, go to another, a more qualified, or seek a second opinion and have an ultrasound done. Sometimes there are other disorders that come in. Some people can have breast pain and they can't explain. So still see a doctor. There are abnormal, symptoms like breast pain, which can be cyclical and will be dependent on the hormones that are produced, or pain on just a particular area of the breast that is normally associated with a particular blood vessel. Anything else that I can think of? There's this misconception or false assumption that implants increase your risk of breast cancer. Breast implants, the silicone or mammoplasties and all that, they don't. The implants are silicone based or they can be tissue based. They are placed, they do not increase your chances of breast cancer. On the converse, when someone has a surgery, sometimes we do use the implants to help them go past that breast cancer stage, surgery stage, so that it looks normal and you're able to live good quality life. Let me see, I don't know, is there any way of, do we have any questions? How can I check on messages? Let's see. Anyone who's willing to help out? There are some messages. How do I look at the messages, guys? Ooh. Yeah, I'm a newbie. How do you get messages? Hi, Noel. Hi, to teach. How do you see the messages? I don't know. I'd have to check on that. But I see a lot of you. I would love to hear what people have to say. Let me see. Is it good that I'm writing people or no? Thanks.
Hello.
Hi.
Hi, how are you?
Fine, thank you.
How are you
Do you
from?
have any questions? Oh, nice. Someone has mentioned I would love to hear about prostate cancer. We will handle that. Anything else? Anyone else with a message? I'm trying to see how to look at the messages. Probably help me. How do you look at the messages?
Okay, bye bye. What? Your country the life. What country the life?
I am from Kenya.
Gunia.
Okay, messages. How do I check messages? Education is educative. Is there any other message? If not, I think this has been fun. I'll probably I'm trying. Who is joining? Hi, Isaac. Anyway, I hope I have answered your questions. I hope this has been good. I hope it has been helpful to 1, 2, or 3 of you. If you have any questions, reach out directly. I would love to do this more. If there are any breast health issues, just I don't know, breastfeeding and how you handle mastitis or anything else related with the breast, we can do that a bit more. How to handle the diagnosis of breast cancer and what questions you can ask, or if there are questions you needed to be answered as well, how you're taking care. If you have nowadays it's so common, we will know 1 or 2 people who are going through this and need help. So let me know. I'm more than willing to hear out and see how best to help. But we also get into an exciting part. We get to talk about men's health, the prostate, and women. Since we men are part of our lives, let's talk about men's health. Let's talk about we've not talked about, I don't know if people talk openly about benign prostate enlargement, prostate hyperplasia, and what prostate cancer is, sexually transmitted infections, and how that can affect your men's health and your urinary issues. What else? Infertility in males, and I know that's something that is a silent killer, or people don't talk about it. Yeah, so if you have any topic you want us to handle, just share that out. Shout out to all of you who've joined. Yeah, you follow me, share this. I think we'll be doing this almost at the same time, but it has been fun. Thank you. Let's do this again some other time. Good night for now. If you have any false assumptions, let me know. Let's demystify them. If you know anyone suffering in silence, also reach out. Just reach out to me, 0721 213 318. If you're concerned about something that you've noticed, just an abnormal lesion, also just reach out. I do virtual consultations as well. And I also offer mentorship and just guidance in terms of career, personal branding for medics as well. So it's been a pleasure. See you guys tomorrow.